Mania is characterized by psychomotor agitation. Mania can be thought of as the opposite of depression, but it doesn't always necessarily feel good. It's not always associated with a euphoric mood, and often patients who are manic are irritable and dysphoric, so it doesn't necessarily correlate with feeling good, but it is an elevated mood, whereas depression is the opposite. And so individuals with mania tend to have a lot of energy. They tend to require less sleep, which is different than complaints of insomnia. People with insomnia want to sleep, they're trying to sleep, but they're having difficulty. Individuals who are in a manic phase don't need to sleep as much, and they aren't trying to sleep typically, and so typically they're not complaining of insomnia. It's usually family members and other people that live with the patient that are complaining that they're not sleeping. There's also symptoms of increased goal-directed activity. These individuals have boundless energy, and so they are ambitious. Often we see grandiosity, big plans. The manic episode can also be associated with hyperspirituality, hyperreligiosity. That's a very common theme. In fact, that particular symptom is pathognomonic of mania. If someone is hyperspiritual, they are definitely manic. We don't know why they're manic. It could be bipolar disorder, it could be schizoaffective disorder, bipolar type, it could be high on drugs, but it always indicates an elevated mood. And hypersexuality is common finding in manic states. If there's too much dopamine in the brain, then that leads to thrill-seeking, pleasure-seeking activities. Individuals with mania are impulsive, but the diagnosis is made by reviewing the history and noting unequivocal signs and symptoms of that disorder. What people usually say is mood swings, and the other common thing is shopping, spending too much money, going out on shopping sprees. But I'm never impressed by that report. Now, if someone tells me that they're going out and they're spending a lot of money on items that they not only don't need, but that make no sense, when a person comes out of that phase, they look back and they look at those purchases, and it's usually large sums of money, but it's more often items that make no sense, that they're not even interested in, they have no use for, and they would never have purchased if they were in their regular state of mind. The impulsivity also includes sometimes unwarranted generosity, giving away large sums of money or possessions. When it's extreme, there can be psychosis, delusions of grandeur, and judgment that's so poor that it's clear that that person is in an altered state. It's very much akin to what we see when someone abuses a stimulant, such as cocaine or amphetamine or methamphetamine, where they are revved up. They have a lot of energy, they're wide awake, they're talking a lot, and they're impulsive, and they have poor judgment. And if someone takes enough cocaine, they will also experience psychosis. Paranoia is very common in mania. It tends to be the grandiose type as opposed to the persecutory type. There are different types of paranoia. And so we see mood-congruent psychosis in these individuals. So delusions of grandeur as opposed to delusions of persecution, because those individuals typically do feel good. And if you see someone who is in an acutely manic state, or a hypomanic state, which is just a lower degree of mania, the clinician sees objective signs on mental status examination of psychomotor agitation, including pressured speech and flight of ideas. Individuals who have mania have disordered thought processes, and it's a spectrum, it's a range, which goes from talking fast and being, for example, over-inclusive, meaning too many details, and the details are largely irrelevant, but the patient is making sense, and they do get to the point, but there's a lot of extraneous details. When that symptom is a little more severe, the patients become circumstantial or tangential, where they're so distracted by the extra details that they'll go off on tangents and they won't ever answer the question at hand, or they won't finish saying what they started to say because their thoughts are racing and they end up talking about something completely different. But you do see also a flight of ideas on the mental status examination. Because thoughts are racing, the individual can't talk fast enough to get all of the thoughts that are running through his or her mind out. And so they're speaking quickly, and sometimes they jump from topic to topic, and their speech can be very disorganized. Evidence of a formal thought disorder, a disorder in the form of the patient's thought as opposed to the content. It's a syndrome of psychomotor agitation and impulsivity and poor judgment, and often grandiosity and hyperspirituality that is a marked deviation from the patient's baseline and that lasts months if it's not treated. And even rapid cyclers, days to weeks. The majority of people don't experience that. The majority of people are talking about going from feeling good, happy, content, to feeling irritable or anxious or sad. And those individuals need to be treated with antidepressants, primarily medications that increase serotonin. And for those individuals, the vast majority of individuals, serotonin, it's not a mood stabilizer in the way that psychiatrists use that term, but it evens things out, it calms things down, it raises the threshold for tearfulness and irritability, and it also has anti-anxiety, anxiolytic effects. And so that person becomes more mellow, more even keel, and that's the proper treatment for those individuals. For individuals that are experiencing actual mania, using antidepressants could actually exacerbate their mania. They could become more manic. But really, what we have to be careful with in terms of treating truly bipolar individuals are antidepressants that are dopaminergic and noradrenergic, that increase dopamine and adrenaline, epinephrine and norepinephrine. Those really tend to aggravate an already hyperexcitable state. And there are many kinds of mood stabilizers of many different classes, but again, they have to be used very carefully because they all have a lot of side effects, and they all have potentially very serious side effects, as well as long-term permanent problems like metabolic syndrome, diabetes, and hypercholesterolemia, and tardive dyskinesia, which is a neurologic condition that can be permanent, in which the patient is left with involuntary motor movements because they've taken an antipsychotic medication like Risperdal or Haldol or Zyprexa for years and years. Most of those agents cause weight gain and significant sedation and drooling, and I mean, they're very heavy-duty medications. And I've evaluated individuals who, for years, have been told that they're bipolar. I particularly see bipolar disorder overdiagnosed in patients with personality disorders, cluster B personality disorders, borderline personality, and histrionic personality, and also chemical dependency. If a person has a known history of stimulant use disorder, then any bona fide manic episodes that they've had must be attributed to the substance that they were abusing until proven otherwise. And certainly there can be comorbidity. Bipolar individuals are known to be at increased risk of abusing substances. So you often see both. You also look at the epidemiology. Major mood disorders tend to manifest certainly by early adulthood, often late adolescence, rarely in childhood, but that's possible. It takes different forms in childhood. Major depression looks more like irritability with behavioral problems in children as opposed to the symptoms that we see in adults. But if a person is experiencing mania for the first time at the age of 68, then that's probably not bipolar disorder. Probably some other etiology. That, or there have been episodes of mania in the past that were perhaps subclinical or missed because bipolar disorder doesn't start in your late 60s.